Welcome to the DRIP podcast, hosted by myself, Angela Craig. I am an advanced practice nurse, a clinical nurse specialist, and a senior medical manager with medical affairs at Baxter. DRIP standing for D, define, R, research, I, innovate, and P, practice. It embodies a patient-centered, evidence-based approach for cutting-edge medical science. Our mission is to foster scientific discussions with the brightest minds in emergency and critical care, with a never-ending ambition to save and sustain lives. Join us as we navigate through topics like fluid management, fluid choice, and shock resuscitation. This podcast is part of a non-promotional education series. Our guest has been compensated for their time and participation today.
Hello and welcome to the DRIP podcast. Today's guest has earned a Bachelor's of Science in Nursing from Wayne State University and her Master's in Administration from Central Michigan University. She is a nationally recognized leader in quality, patient safety, and critical care. Pat currently serves as the Quality and Safety Program Manager for the Hospital Medicine Safety Consortium. With more than 45 years of healthcare experience, she is widely known for her work in sepsis management, ICU safety, and clinical improvement collaboratives nationwide. Pat is also a fellow of the American Academy of Nursing and serves on the Sepsis Alliance Board. Please welcome Pat Posa.
Hello, everyone. This is going to be an amazing podcast today. I am your host, Angela Craig, a senior medical manager with Baxter, and we are going to discuss the updates to the sepsis guidelines for 2026 that were just published in March of 2026. Woohoo! Pat is definitely an expert in this field, and we are grateful that Pat Posa is here with us today sharing with us. So, Pat, I know the introduction told us about you, but just share a little bit about what you are doing these days.
Well, so I have a couple things I'm doing. So I work as a quality and safety program manager as part of a collaborative called HMS, Hospital Medicine Safety Consortium in Michigan. We're a collaborative that's funded by Blue Cross Blue Shield, and one of our focuses is to improve sepsis care. And it's not just the initial early identification and management, but it's through the whole hospitalization and beyond. And so I assist hospitals in improving their care.
Awesome.
So yeah.
That's great.
And then I'm also working to assist the University of Michigan in putting in place an enterprise-wide sepsis program. And so lots
Awesome.
of fun sepsis-related stuff.
Yeah, that sounds great. I love that. Well, it's great that we can be here and chat about these new guidelines. I know we don't have time to go through all 129 statements, but I thought maybe we could focus on some of the changes, and maybe we can just summarize the 8 areas that they categorized. And I think that just might make it a little easier for us. We're going to start with screening and early management. Did you feel like there were a lot of changes? And if so, can you kind of summarize those for us?
Well, so I think that the couple big things. So one of the big things was they started to recognize the importance of screening pre-hospital, right? And so that had never been called out in a guideline. We know that in managing acute MIs, right, they start in the field to recognize, and that expedites care. And so putting in a screening process in the ambulance or in the air, helicopter or whatever, en route. And so that's a big change. Now, there are places that have been doing that. I know when I worked at St. Joe's in Ann Arbor, Michigan, we back in 2010 worked with our ambulance service and put in a screening process so that when they would call in on the radio, they would say this patient is screen positive for sepsis, and they would, if they were hypotensive, they would start fluids. They weren't giving antibiotics, and so the new guidelines do recommend, if the distance, right? So, the majority of the United States is rural, right? And
Right.
so
Right.
sometimes it takes a while by ground to get somewhere. And so if you have, the guidelines recommend, if you have a patient that is hypotensive and is screens positive for sepsis, that you should give antibiotics, and it's going to take over an hour to get
Hmm.
to a facility, you should give antibiotics en route.
Yeah.
So that's new. Um, and then the other big thing, they reemphasize the importance of screening and having standard operating procedures, but they also talk about putting in a code sepsis or a sepsis huddle
Yes.
to improve the communication of the team, to similar to, I mean, again, this gets modeled after other disease processes that we've done this, stroke alerts are standard in hospitals, right?
Hmm.
And so there is some literature supporting that it does expedite care, and that's its purpose,
Hmm.
right? You
Sure.
come together, you talk about, okay, is this sepsis? Okay, let's start everything, right?
Absolutely.
Um, and sometimes you're bringing in more resources. Then you call a code sepsis overhead, and additional resources comes to expedite getting those antibiotics and the fluids. Do you need another IV line, et cetera? So I think that's big. And
Yeah.
we also saw that as one of the suggestions in the CDC's core elements for hospitals, sepsis program core elements.
Yeah.
Um,
And another thing that struck me in that beginning section was something about making sure your hospital has an improvement program or a quality improvement program or something to that effect. And they talk about that also in the core elements. And I think it's important. We talked about this too at the Tennessee Hospital Association with our sepsis collaborative. We talked about how important it is to almost like be able to spell out our performance improvement plans. Like, what is it that we're really focused on? What are we doing? How is that working? And then do we need to read, that PDSA cycle, and
yep.
what
Yep.
can we do to make it better? And I think a
You
lot of
can't
us.
say, yeah, you can't stay stagnant, right? You really,
Exactly.
yeah.
Exactly. That's a good point. Well, we're not going to belabor that this point along because we've got many other to cover, but really important items you just really alluded to. And secondly, there was the infection section. Was there anything that kind of struck you as different or something we should maybe mention here?
Well, so for the antibiotics, right?
Hmm.
So for um last in the 2021 guidelines, they introduced a framework in how to approach giving antibiotics based on if the patient was in shock or not, or hypotensive or not. And so they reinforce that, right? It's a new graph,
Right.
it's got some definitions on it, but the message is the same, and it's a stronger message. The evidence is stronger that here you have a patient that's presenting to you that is hypotensive, right? Something is causing that. If you even have an inkling that it might be an infection, that it could possibly be sepsis, get antibiotics in rapidly, right? So
Right.
order those antibiotics, get them in within an hour. Even if the patient is not in shock, but sepsis is likely, it's
Right.
probable, give those antibiotics in an hour. And it's only when you have no shock and sepsis isn't necessarily high in your differential, it's there, but
Right.
there are other things that you think might be happening, then do that workup, right? Do that
Absolutely.
workup that says, is there an infection here that's causing these symptoms, uh, um, or not? But then still do that rapidly. Get it done within
Yes.
3 hours so you can get the antibiotic ordered and hung. So
Yeah,
that's a reinforcement, right? And a
for sure.
continued reinforcement of how important it is to get those antibiotics in early.
And I think it was in this section, I can't remember, the decontamination part that was felt new to me.
Yeah,
Was
yeah.
that
So
in this
they
section?
Yes, it was. Yeah. So it was the selective decontamination of the digestive tract. And so this has been going on a while, not necessarily as much in the US, but in Australia and Europe.
Mhm,
And it finally got to a point where they've perfected it and
mhm.
it works. And so you're decontaminating the oral and nasal pharynx. And then you're decontaminating by giving some IV antibiotics. And these are antibiotics specifically aimed at the eliminating the harmful bacteria,
Mhm.
not the good gut bacteria, the
Right,
anaerobic, and that's the importance of it, right?
right.
Um, and so yeah, so that's gonna be new. That probably will be one of the challenging things to implement from these guidelines because I think it's been off people's radar,
Mhm.
and really hasn't been talked about as much. We know
Right.
the MRSA prevention stuff, but yeah, so I think it's good.
Yeah, I
But
think it's good
it
too.
will take a little bit to get
Sure.
all the ducks in a row to be able to do this as a standard on that ventilated patient in the ICU.
Right, and I think updating our policies or updating our protocols, things like that, and our order sets will definitely have a little bit of work to do there as well. Yeah.
Yeah,
Okay, so
and
then go ahead.
And
Sorry.
the other thing in the antibiotic section is just in re-emphasizing the importance of de-escalation, right? That
Absolutely. Yeah.
that you're going to start that broad spectrum antibiotic and you're going to start it quickly, but you're going to de-escalate as soon as possible to prevent those that resistance or any harmful effects. So that was another emphasis in that section.
Yeah, for sure. And then, of course, the next section is probably my favorite, hemodynamic management. You know, that's my favorite. I love the idea of precision fluid management. And so, just share with us a little bit about how maybe that changed.
So they I loved the guide that they created,
Mhm.
a quick guide for resuscitation and hemodynamic supports that talks about that early, right? The
Yeah,
the
that
initial
algorithm was
phase,
nice. Yes.
and then once you've done that initial fluid and started the vasopressors, then how do you approach it? So it is re-emphasizing the importance of being precise when you choose, does this patient need additional volume? It still is very strong in saying give that 30 milliliters per
Mhm.
kilogram, right? And they expanded the population to give that to, right? They
Right.
lowered they said, lactate greater than 2, not just waiting till the lactate's greater than 4, that those patients have shown to have benefit and less likely to progress into shock. So, but once you've given that 30, the fluid overload that we see that people fear doesn't come from that 30. It comes from what you do after that. And so it's really about being precise. And the recommendation, again, is to use dynamic measures to do that, not static measures. And so using stroke volume, right? Using passive leg raise or a fluid bolus and testing, looking for that change in stroke volume. If it's greater than 10%, that patient is volume responsive. It means they're still on that steep portion of the Frank-Starling curve. If it's less than 10%, they're not volume responsive. So don't give them fluid,
Right. Go to what
right?
they need. Right.
That's not what they
Right. For that
need.
moment.
Yeah, at that moment. And it can change. It can
Yes.
change, but
Yeah.
but it's really that fluid that we give I don't want to say willy-nilly, but we just give,
Yeah.
right? After that initial 30, that becomes the harmful fluid.
And,
Um,
I've even heard of it called like
Potentially, right?
fluid creep, like even just those fluids from all the antibiotics, from, keep vein open fluids, all that fluid creep can actually turn into a
It
significant
adds
amount.
up, right?
Yeah.
Well, and the recommended practice is to have moved away from putting on a maintenance fluid.
Hmm.
You don't need maintenance fluid,
Right.
right?
Right.
Just bolus. And it's that maintenance fluid that causes a lot of that creep, right? You might not
Right.
be able to get rid of the fluid volume that's coming with the antibiotics or with the
Right.
vasopressors and stuff like that. But I don't need to have an IV at 50 cc's an hour
Right.
as a maintenance, right?
Right.
That just piles up real fast.
Yeah, it
And
really
it's
does.
probably D5.5, so it's not really helping.
Yeah.
So,
Yeah.
um, yeah, so it again solidifies that we need to be precise when we're deciding to give this patient additional fluid.
Yeah, for sure. And I think it gave it a little better rating than the last time, or it encouraged it a little bit more based on the rating system. So I was very happy to see that. Okay, that's my favorite section, but let's go on to the respiratory support section. Anything there that we should be aware of?
So I think that they again reinforced that heated high flow is the better oxygen therapy if you need a higher level oxygen therapy. And so that was reemphasized. And then also using low tidal volume
Hmm.
ventilation before someone gets to ARDS, if they have hypoxemic respiratory failure, but you're doing it at volume of 6 to 8 versus the 4 to 6 when someone is in ARDS. And then they also call out the we love the PF ratio, right?
Hmm.
But a surrogate for a PF ratio is using your SAT to FiO2 ratio. And so I think that was an important call out to, it's not as precise, but if I don't need to get a blood gas and to
Listen.
get my PF ratio, let me use that SAT to FiO2 ratio.
Yeah. And one of the things that they mentioned that I hadn't really thought about with my septic patients, and I don't know why, but if it's that patient who is having some, or looks like we're heading toward potential ARDS or whatever, having them do self-proning.
Oh, yeah,
And I
the
think
awake
that's,
proning. Yeah.
yeah, the awake proning. And I never told one of my septic patients, hey, why don't you go ahead and lay on your belly? And it's such an easy thing to have these patients do, right?
And I was thinking, did they ever mention in 2021 awake proning? I don't think they
I
did.
don't recall
I,
that.
I don't think they did. And remember, awake proning became the thing with COVID, right?
Yes, it sure
When we
did.
were attempting to prevent to intubate. We didn't want to intubate these people, right?
Right, right.
And so yeah, so awake proning, I think has its place.
I do
But you don't
too.
think about it, right?
Right,
So
right.
we've thought about it less after COVID. It's not something that comes into mind, but it's definitely something that we should put back into our practice, right?
Yes, for
Um,
sure.
in that population.
All right, Pat. So next would be talking about some additional and adjunctive therapies.
Yeah, so one of the things that they called out was to suggest against using antipyretic therapies,
Hmm.
just to bring the fever down, to bring the fever down for fever's sake. Um, and so I think that's just something to step back and think about it. Do we have to treat every fever that goes above 101? We really don't, right? Or 100.4. So they are suggesting against doing that. Now, this is not targeted control that they're suggesting against for the neurocritical care patient or the post cardiac arrest. It's just because we know fever is a compensatory mechanism, right? It's the
Right.
body's way to rev up that immune response and metabolic rate. And so I think that's the um rationale behind it. And they've seen no, there were no outcome studies that said by reducing the fever I improved the patient's outcome.
Right, right. And then too,
So
if we continually just give, even for those lower temperatures, then if they were to respike, we might miss that, right? And
yeah,
so we
right.
want to
You're
be able to
masking
know.
something, right?
Yeah,
So, you're masking that respike of the fever that might signal you to say, maybe I don't have the right source, right?
right,
If
right.
right?
Good
So
point.
yeah, so that is good. And in this section, the other thing they just reinforced really was that there's, you know, we suggest against using vitamin C. We suggest against using immunoglobulins or vitamin D therapy unless there's a nutritional reason for it. So
Yes.
that was really just reaffirming those
Hmm.
things.
Yeah, that's great. All right. So the next would be summarizing the goals of care. But you know what? I think we're going to skip that one just because a lot of those were carryover. Feel free to refer to the 2026, the new guidelines. And I found that it referenced us back to 2021 a lot of times as well. So don't throw those out either in case you are reviewing. But I think maybe we'll go on to transitions of care because I do think there was some information in there that was newer for us.
Yeah, and Angela, I think in the goals of care, the only thing that was really new is uh, recommending that you have advanced directives
True.
discharged in place before the patient goes home.
Yes.
But I know in hospitals that's been a mantra for a
Oh,
long time,
absolutely.
right?
Yeah.
When you come in, we ask for them, and so we can put them
Yeah.
in, right?
Right.
So it's good to think about, right?
Absolutely.
But yeah, so transitions of care. Love transitions of care. And, what's nice about these guidelines is that they do have such an emphasis on not just that acute phase,
Right.
but they have the emphasis on, okay, what do you do then? Right. And so in the transitions, they talk about, again, the importance of medication reconciliation. And it's not just at discharge, it's as you transition in the hospital to different areas. So I thought that was important. And they do a call out of a pharmacy led might be a good option. And then they talk about the importance of patient education and educating our patients and
Mhm.
families about sepsis and what it is, and that this patient has sepsis, and what's the treatments, and that you're at high risk for getting sepsis again,
Right.
as well as that there are you might be feeling some symptoms and things that are part of this thing called post ICU or post sepsis
Mhm.
syndrome, and really
Mhm.
educating patients and families on that because they walk out and they feel like they're in a mental fog. We
Mhm.
heard a lot of that with COVID, the mental fog
Yes.
and stuff. That's been existing for a long time, right? We
Right.
just haven't called it out. And so letting people know that that's not abnormal. This is something that you might experience. So they get again call that out. And I think that uh, patient education and family education is something we don't do well, um, just in general, in this population.
Mhm.
We know our colleagues at Sepsis Alliance who do a lot of patient and family surveys and have a lot of focus on patient and families, and they consistently identify that a lot of patients never heard the word sepsis when they were in the hospital. And so how do you even know how to link to resources and stuff if people aren't even telling you what you had, right?
Right.
So
Honestly, sometimes as I think about all of these guidelines, I feel like this may be the area that deserves, I mean, every area is important, but this may be the one that deserves the most work. I feel like we've really learned how to identify patients quickly. Well, I hope. Most institutions, I think, at least know what they're supposed to do that. But when it comes to some of these transitions of care, and also I think for just like primary care, what about these providers that are out in the field, and when these patients show up on their in their in their units, not units, but in their
Your
care
clinics.
areas,
Yeah.
clinics, yeah, and care areas, are they getting what they need? And preventative wise, and then also I think of the cognitive needs of these
Yeah.
patients, like you mentioned, the fog, and what can they do to help with that? So I think we have a lot of work to do on this area, and I hope that we'll just continue to grow in this area for sure.
Yeah, it is really lacking, and you bring up a great point that, the post-hospital people don't know all this, or, they're doing that. I've heard comments from patients, "I'm going to this, I have to get in for a visit in 2 weeks," and I get to my PCP and they say, "Well, what are you here for?"
Mhm.
Right? I mean, so we have to bring that education to the primary care providers that they need to understand this stuff, and they need to be doing some screening for cognitive
Absolutely.
issues, mental health issues,
Mhm.
and functional issues, right? To
Right.
make sure that then they're linked to the right resources. And yeah, it's such a field that is still so new, and we're
Mhm.
so void in knowing exactly what to do. We don't.
Right.
Um, we have things that we can do to try and prevent all of this stuff from happening by giving
Mhm.
early sepsis care. And if they're in the ICU, doing that eighth ref bundle, doing the ICU
Right.
liberation bundle to
Right.
try and help prevent, minimize the sedation, get them up and walking.
Right.
Um, uh, but we don't have, there's some early studies on um, uh, just reorientating,
Mhm.
every time you come into the room, that helps improve.
Mhm.
People are doing things like Sudoku and other,
Okay.
computer games and stuff to help,
Keep their brain working.
keep their brain going, help restore some of that executive functioning that they might have, lost for a little bit. So, yeah, there's so much we don't know, you know, and
Right.
and we don't know how to improve it yet. We
Mhm.
know with the functional what to do, right?
Right.
Physical
Right.
therapy, occupational therapy for the help with the ADLs, but we're still, and if we identify mental health issues, that we know what to do. But the cognitive stuff is still challenging.
Yeah, we have a long way to go. And I might have kind of eased into the last one, which is
Yeah, which
long-term
is the long
outcomes and
term. Yeah,
recovery. I think I kind of maybe transitioned us to that with the transitions of care. I think it kind of all goes together.
yeah.
Was there anything else you wanted to touch on that long-term outcomes and recovery?
No, just the importance of, um, setting up systems in your hospital where you're evaluating for deficits, right? You're
Mhm.
evaluating for new deficits, and then you're linking people, with the appropriate resources. So we don't necessarily, that's not part of our necessarily our discharge planning process, right? Is
Mhm.
to assess for, deficits in functional, cognitive, or mental.
Mhm.
So should we do? I mean, one of the things as you think about someone that has had sepsis and maybe delirium on top of that,
Mhm.
um, and and then we send them off and we don't give them any kind of restrictions. They probably shouldn't be driving. It probably
Right.
might, there should be, don't handle heavy machinery. I mean,
Yeah, exactly.
there should be some guidance that we give them when they're leaving the hospital, but we don't know that guidance yet. We don't,
Mhm.
but it's kind of because so Jim Jackson out of Vanderbilt, I don't know if
Mhm.
you know him. He's in their post ICU clinic, and you know it's a challenge. They do a lot of that work when they see the patient 2 weeks after,
Mhm.
hospital discharge, but not really before. So in those 2 weeks, you know,
Yeah,
gosh,
a lot
how
could
are you
happen.
managing your meds? How are you, you shouldn't be
Yeah,
driving. Uh, so we have a long way to go. But
yeah,
it's great that the guidelines are calling out that
calling it out.
these are important
Yes.
to think about and to align resources. So I think that's great.
I do too, and I think, it's made me think, and I know at times, during our in some of the past sepsis, meetings we've had, we've included families or patients, and we'll just have them come on, and whether it's virtual or they're welcome to come in person, but, and just ask them, "What went well for you? What were what were you surprised about? What did not go so well?" And I think also just us communicating to know what the perception is once they go home can be very telling and
Yeah.
can and many times if we ask they'll sure tell us, right? So I think staying in that state of always wanting to make things better for your program and for these patients. But I know we have just covered a lot in a very short period of time, and I want to thank you, Pat, for going over that with us and taking time out of your busy day to share with us. There may be somebody listening today and they say, "Man, I need to talk to Pat Posa." How do you suggest they best do that?
So email probably
Awesome.
is the best, and patposa07@gmail.com.
Okay. Okay.
If they have any questions or anything, and I'd be happy to help answer anything. And but you know, it's all about the patients, and I think these
Absolutely.
guidelines are very well written with great guidance on
Hmm.
what we should be doing.
Absolutely. Well, thank you so much, and thank you all for listening today. And we hope you have an amazing rest of your week.
Thank you, everyone.
As we conclude today's episode, I remind our esteemed medical colleagues that the opinions expressed herein are solely intended for professional discussion and should not be construed as medical advice. We encourage all listeners to consult their own healthcare providers for personalized medical guidance.